So it's cool. I did put together a couple slides for you guys. Happy to show them if you want, or we can talk about anything else you want.
No, go ahead and start with your slides.
I guess you guys talked a little bit about the election.
Yes.
And about you know, I have to admit, I tried to. So I have worked for some of the political parties on both sides of the equation. And I asked whether it would be okay for this particular group, whether it'd be okay if I showed some material that I created back in May, because I knew you guys were trying to talk about elections. So if it's interesting, I can show you some of the things that we were thinking about back in May, and we can see if some of those things came true.
Sure.
So, okay. So this is what I was thinking about back in May. Let's see if I can't. I've tried to, as I said, I've tried to sanitize this. And as I said, I've worked with both parties, so this was from one particular party, and I hope you can't tell which it was from, but you never can tell. So the first one of the first things I did was I tried to predict where COVID would be an issue, right? Because I'm a COVID person, and I was interested in what was going to happen with COVID, and so you can see that I was predicting based on two factors. One was the prevalence of COVID at the time, and the other was concerning the policies that were implemented at the time. And so it was likely that where you had lots of COVID and they had policies that were actually either quite constrained or quite open, you'd have populations that were upset about, hey, wait a minute, we don't have that much COVID, so therefore we shouldn't have all these constraining regulations. Or the opposite, gosh, everyone's got COVID and we have nothing and we're feeling unprotected. So those are the kind of the two factors we were looking at. One would tend to make the Republicans more likely to be elected, and the other would make the Democrats more likely to be elected, right? So overall, you can see that in May I was projecting that these were the cities and the population areas that were going to be the most affected possibly by COVID. And I thought that Alabama was going to have a big problem. And I thought the Northeast coast was going to have a bigger problem than it ultimately did. So I was wrong about 2 and 3. Chicago had a big outbreak. St. Louis is having trouble. Miami, of course, obviously having a lot of trouble. California isn't having trouble. So I was wrong about number 7. I was worried about Los Angeles at that time. They were having a big problem keeping things down. Atlanta, I thought, and is having a big problem. Texas is, I thought, and had a big problem. Ohio also isn't as bad as I thought it was going to be. So that was good. Tennessee, Nashville, Memphis East has gotten challenging. Indianapolis is a problem, and Central North Carolina has had issues. And I missed Wisconsin. You'll see later, though, that when you put all the factors together, these are the states that I thought were supposed to where COVID would play the greatest role in election of the president. This is for the one of the national parties, and you can see that I thought that COVID would play the biggest role in Florida, Pennsylvania, Michigan number 3, North Carolina, Arizona, Wisconsin. I think I would push now Wisconsin ahead of Michigan if I had to guess. But don't forget, Wisconsin is quite a bit more Republican leaning than Michigan. Michigan was more a toss up. Then Texas, Ohio, Georgia, and Iowa. Those all were and still are very much in play. The Democratic conversion states, Maine, South Carolina, Alabama, and Mississippi were possibilities. Republican conversion, Minnesota, Colorado, New Hampshire were possibilities. So this is where and then you put it all together, the maps and the priorities for the different parties came out to look like this. And so you can see that, in fact, if you look at a map today, you'll see that people are flying to Arizona. They are flying to Michigan. They're flying to Wisconsin. They're flying to Georgia, and they're flying to Florida, and North Carolina. So this all basically, came. If you look at where COVID was going to be was going to play the largest role, the swing state tiebreakers, you can see that, in fact, that is the case. And so you can start to then focus on various counties and populations that you thought were going to be more affected or less affected. And when you do that, and you can see that, the Democrats, for example, would have to if they lose any of these big swing states, then they would have to at least hold these. They'd have to at least hold Minnesota, Colorado, and some of the East Coast states. Whereas if the Republicans lost, they would have to at least some of these swing states. They'd have to at least hold South Carolina, Mississippi, Alabama. because those are the ones that were most at risk for COVID. Now, this is only about COVID and where you want to talk about COVID. And then, of course, the next step was to actually get to the state level and try to figure out, which states were most likely to move on the House of Representatives. We also did this for the Senate. We also looked at local, runs and state legislatures to see, and governor runnings, and so all those were basically looking at, just from a perspective of where COVID was going to be an issue, based on policy and based on where likely outbreaks were. Where you'd want to kind of focus on that So you can see that Michigan it is a huge player in this space. So our votes are really important. So everyone should get out and vote, because we're going to determine the president of the United States in about 20 days.
Interesting.
So that's sort of what we do. When we look at a single policy issue and it's dependent on healthcare, then you start to say, okay, where are policy and bad or good health related, and where can you make that, or should you try to make that an issue, especially when you're in a state that's in an area that's likely to turn one way or the other. You don't want to go, full blast of California for Republican, because it's pretty much all blue. But you sure want to start to look at, at trying to protect what you've got in Michigan, for example. So that kind of thing. That's the sort of thing we look at. So this was in May. I've worked for a number of campaigns, or with a number of campaigns. I don't charge for my work in this particular case, because I'm trying to be objective and open. That's my job. But all the parties have come to me, and a number of states have come to me on these issues. So I just wanted to kind of show some of those things, if it's interesting. One of the things that's happening, of course, that I also wanted to talk about was death rates. And what's interesting is that there are two sort of competing factors that you've heard about in the news. One is the factor that says, gosh, there's a slight bonus for claiming that your patient has died from COVID. There is a slightly higher reimbursement rate as a result of a COVID attack. And that's to try to compensate the hospitals, because they weren't designed to treat nothing but COVID patients, and it's very expensive to treat them. And the reimbursements really weren't set up for a surprise virus like this. And so we're trying to compensate the hospitals so they don't all have a lot of financial difficulty, because they're treating a very different, set of diseases than they typically do. And so we've given them, and the CMS, said, because you are focused on the pandemic, which you should be, we're going to give you a little bit more reimbursement. And so people have pointed out correctly that, if you do say that you've got a patient that died of COVID, that you are going to be reimbursed a little bit more. And so people say there's a slight incentive to move when things are 50-50, or there are multiple causes of death, to say it's COVID. If you do this without objectivity, that's fraud. So it's very unlikely that any medical doctor is going to risk his entire practice for a slight a bump in reimbursement. But we think it could be the result. It could swing it by up to 10%. What we do know, though, is that we have a pretty steady number of deaths every year. And you can see, in 2017, 2018, 2019, and the way you really tend to look at whether you're having an excess number of deaths and what that number is versus a normal number of deaths is you look at the trends for the past few years, and then you look at how much extra deaths have been recorded. And then you say, could this be related to COVID? And so when you do when you do that, I did this in September 1st, and I looked at, the whole swing here. And basically, I thought that on September 1st, we were claiming 185,000 deaths, and the actual number was probably closer to between 250,000 and 300,000 deaths. So quite and that was because people died without people realizing that it was COVID. It was a new disease, novel virus. People died at home, and there was without symptoms frequently, or with strange symptoms that were thought to be heart attack related, or respiratory attack related, or an asthma related, or from diabetes or pre-existing condition. And so they said, well, that's obviously a condition. But if you really look at the numbers, it looks like we have probably about 20 to 25% more deaths than we've actually reported. And as we get better at reporting COVID, that this number will start to decline. As you see toward coming off the graph in September, we're starting to get better at diagnosing and understanding what the COVID deaths are. But overall, we probably have had more deaths from COVID, not fewer. Those are the factors that one thinks about in that space. So when you think about COVID deaths, I'll just show you, as you know, the sad thing is, I think we're about to go, and you've seen this slide before, so I won't go through it in detail, but you can see that you can project a number of different scenarios with COVID, and I showed this slide before, and you could think that, we're going to stay at about even right now, about 1,000 deaths a day across the whole United States, versus it could look a lot like, certain areas in Europe, for example, almost went to zero when they went up through their first, well, maybe it was going to go down. But in fact, when you do all the work, and there are about 30 different modelers. I do my own models, and I'm in concurrence with most of the other modelers that we're going to have a very big peak. And you can see that one of the biggest reasons for the big peak is because we have no medicine and no vaccine backstop. In a lot of the other disease areas, we have a medical or a disease backstop. And like in the flu, we've got the flu vaccine, we've got Tamiflu, we've got a number of things that aren't perfect, but they start to at least reduce the virulence and the amount of transmission you have in the virus. We have nothing for COVID. And so we're going to be facing what looks like, because we haven't actually controlled the virus, because it's moving into November, it likes the cold, because we're all going to be moving inside, coming together, because it's flu season, because we haven't really tested enough, and we've got no herd immunity to this thing. It's basically 90% of us are susceptible. We are just entering what I think is going to be the worst phase of this virus. We've predicted this before. But what happened on Friday was interesting. On Friday, Pfizer announced that they no longer were going to try for a November 1st approval, EUA for the vaccine. And I told you that was a possibility, if you remember. And it was. On October 15th, they had one last analysis. The way Pfizer runs their work is they're testing 44,000 people. And they are looking at cohorts of 500. So every time you close off 500 cases, you look at that cohort, and you look at immunogenicity levels, you look at transfer levels, you look at how many of the people have symptomatic disease, and that's the primary endpoint. How many people in the placebo group didn't get an active vaccine, and how many people who are in the vaccine group got a symptom of COVID, and then when you tested them, did they have it? That's the endpoint that's the clinical endpoint for the Pfizer test. So they closed off on a big cohort of 500 on October 15th, analyzed it, and they announced we don't have enough confirmatory data yet, which means we're going to have to wait another 2 to 3 week cycle for another 500 to be looked at until we possibly have the data. And they said that they think that by in the late after the midpoint of December, and they'll take another cohort analysis, I think on December 20th. They should have enough data. So what does that mean? What does that mean? And the answer is pretty surprising. It means 135,000 more people are going to die in the United States.
By the end of the year?
Overall. So by delaying this by a month, so what happens is basically they announced we are going to delay from November 1st, which we thought was possible, to start vaccination and submit to the FDA. We're going to submit now instead of November 1st. We're going to now submit December 15th or so. My projection is December 20th, but December 15th or so. Well, that's 45 extra days at 3,000 deaths per day, right? Because we're moving right along here at a very high death rate. So yeah, it's probably worth about 130,000 extra deaths that delay.
At 3,000 deaths a day, do we get back to the point where there's hospitals overloaded? I heard a very troubling report out of St. Louis last night that there were 6 hospitals turning away ambulances because they didn't have beds. I mean, are we going to get to that point again?
In areas of outbreak, absolutely, we will. Unfortunately, Wisconsin will have that, Florida will have that. So we'll look for areas of outbreak. Overall, in the United States, we need to get to about 7,000 to 9,000 deaths per day. That if we got to 7,000 deaths a day, we'd start to hit for the entire country to have trouble. 9,000 deaths a day, we would be having people being turned away untreatable. So yeah, we're getting toward that.
Fred, I have a feeling I scheduled to have my other knee replaced on January 3rd.
I wouldn't do that.
I have my doubts about that date right about now.
No, I would not do that. That is not going to be a good scenario. Trust me. Yeah. Because the other reason it's not a good scenario is because what happens is if everyone got together on and had a grand time on New Year's Day, the period of catching that of actually becoming symptomatic is about 2 days later, which is about January 3rd, and that they will be all asymptomatic or pre-symptomatic of the disease. So it is I would not ever schedule January 3rd at this point. That would be sort of the worst possible date, I would think, sadly. So you just cancel that now and wait till the spring.
Well, that also brings us, now we have the great family reunion season coming up, Thanksgiving, and of course, Christmas. So I guess if we have dysfunctional families, this gives us a great excuse now to say, I'm sorry, I can't attend.
Couldn't possibly make it. I'm really sorry. COVID is really worrisome. Yes, there is. I think it's a legitimate excuse. I would try to avoid a family get together. Sadly, I mean, we usually have 40 people come over for Thanksgiving in our house. All the families, all the generations. It's a great time. It's a really wonderful time. And this year we're just gonna be Betsy and I. It's gonna be the two of us. That's it.
We are at this point still planning on a gathering of 6 for Thanksgiving, but all of us work from home. So I mean, is that?
Yeah, I would say 6 is about the max. Yeah,
okay. All right.
And I would try to keep Thanksgiving dinner to less than an hour if you can. And don't go buffet.
And crack a window or something. Yeah. Okay.
Have it all plated up and just deliver. Do not serve and transfer food around. Just yeah, it's going to be a challenge. I'll think about Thanksgiving. What health policies we should do, and we'll talk about that. When the date comes, we'll do that. That's a good idea. Basically,
it's only a month away.
And what's interesting is that I'm concerned that the election is going to actually influence, who is elected is going to influence when we're actually going to see this vaccine go out, right? So suppose that President Trump wins his election, wins re-election. I think at that point, Pfizer will be very motivated, and the FDA, who reports into President Trump ultimately, is going to be very motivated to make sure that their review goes as fast as possible. So maybe 2 weeks, right? 2 weeks is the absolute minimum. So then you're talking about a January 1st. If Pfizer's right, here it is, FDA, go. Pfizer's right, then it'll be January 1st. Well, on the other hand, if Vice President Biden wins the election, and you're the FDA commissioner trying to score points, you probably wouldn't want to. You probably want to wait till about January 22nd to actually announce a wonderful news.
Yes, sort of like when the day the hostages got released in Iran was not a coincidence, right?
I shouldn't be cynical. I think the FDA is a very, very straight up organization, right? But I'm just, you can't help but say, wait, you got a lame duck situation. I am appointed. I probably want to make sure there are transition teams. I don't think this is going to be a very happy transition if it moves toward Biden.
To say the least.
So yeah, and if it's with Trump, I mean, they're full blast, right? So they're going to go pretty fast versus a transition that has some challenges. So that means that you have a first vaccination. So that these vaccinations take 2 times. So first vaccination will be January 15th. If you're between then and maybe as long as first vaccination until February 28th, the last day of February. So we have a sort of a window there, and then you have the second. You have to wait 28 days for the Pfizer vaccine, 21 days for the Moderna vaccine. So around between February 15th and April 1st will be injection 2, and then you got to wait another 2 weeks before you really have immune system effect. So that first vaccine, that first wave of vaccine, which will be 20 million vaccines, it'll 17 million or so of those vaccines will go to healthcare workers, which is appropriate. You want to keep them safe and not spreading disease. About 3 million will probably be essential workers and very compromised or elderly patients. And so that's the mix. So we probably won't have any effective vaccine through probably, on average mid-March, I would guess on here. And that means we're going to have to go through this entire period with the flu season, and I think it's going to be the worst period that we're going to face with COVID with nothing. We have really nothing to stop it. So I hope that makes everyone happy. I'm sorry about that.
Nothing to stop it except for masks and social distancing and hygiene. And that's all we got.
The point, Matt. And that is exactly the point I wanted to make. Don't let your guard down, and please get better at using this non-pharmaceutical, washing hands, using masks, all that, because that is going to be the key to staying alive for the larger population at a population level through at least April of next year. For everybody, and we probably won't, the average people of me, who's under 65, relatively healthy, I don't anticipate getting a vaccine and having any hope of immunogenicity, any level of immunogenicity until at least the quarter one, quarter two of 2023. I'm sorry, 2022. If we're super lucky and get a vaccine at all, right? So. So be ready with your masks. I know it's a huge pain, but it really is going to be the method we've got to reduce spread for a long time.
Yeah, I'm seeing a lot of memes lately that you may be done with COVID, but COVID is not done with you. So
that's the problem. That is the problem. It's relentless. It will find you and hunt you down. If you make a mistake, it just takes one mistake and it'll find you. And sadly, if you're susceptible like we all are, it'll kill you.
All right, we only got about 2 minutes left, and I know Dave has a hard stop right at the top.
Well, do you guys have any big questions? Are there any questions that you guys have?
Well, I had mine answered. Mike, you got anything?
Just that from what I can see, although certainly older people with underlying conditions are a prime area that could get it, it seems to be spreading over the whole population right now. Younger people, middle-aged people, older people, everybody's getting it, right?
In fact, statistically, the super spreaders tend to be teenagers. Statistically.
Yeah, they're less cautious. And I remember being 19, I thought I was immortal, so it's okay. It's not surprising.
So it really is incumbent on us to kind of explain that this is maybe not so dangerous for them, but it is very dangerous for their community, people who they care about, like grandparents and others. So
all right, 1 minute left, so let's tell people how they can get more.
Oh, absolutely. FredBrown.com. Please feel free to ask me any questions you have. I'll be happy to answer them, and take a look at all the material. All of this material is up there, as well as a little bit more. And I'd love to have you come in and see what you think.
Traditional four-year students love Lawrence Technological University's thriving campus life. But LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.